So it's a new old topic, and as you know, the renin-angiotensin system is very well known. You have learned this slide at your medical school. So the liver produces angiotensin, and angiotensin gene is cleaved in angiotensin 1, and after that, in the lung, angiotensin in converting enzyme cleaves angiotensin 1 in angiotensin 2, and then you have the peripheral effects of angiotensin 2 on heart and vessels, and also on kidney. So what happens during septic shock with renin-angiotensin system? How RACE behaves? So during septic shock in patients, we show that we have an increase in plasma renin activity, and we have an increase in angiotensin II concentrations. The problem is that the effect is completely blunted in periphery and on vascular system and heart, as you can see on this slide in an experimental model in rats. We have a challenge of rats with endotoxin, and the author report an increase in plasma renin activity as well as plasma angiotensin II concentration, but the peripheral response with aldosterone is completely blunted. So what happens at the receptor levels? This slide shows you the effect of LPS load or leukotriene acid in a rat model, and as you can see, the sepsis or sepsis-like model induces a decrease in angiotensin 1A and B response with a parallel increase in nitric oxide synthase 2. And it is true for adrenals, it's true for lungs, it's true for kidney and heart. So when we give inhibitors of nitric oxide synthase, such as L-NAME, we restore the receptor's activity, and when we give agonists to nitric oxide synthase, such as sodium nitroprusside, we decrease the expression of receptor of angiotensin II. So the response is mediated via nitric oxide synthase and nitric oxide. So to summarize the response, it's like similarly to adrenergic and vasopressin responses during septic shock. The renin-angiotensin system is activated, but the vasopressor response is blunted due to downregulation of the receptors of angiotensin II. So what happens now when we administer angiotensin in patient or animals in shock? There are very few data, as you can see, and some case reports are reported, but only 3 significant or reliable studies are available, 2 in animals and 1 short pilot study in patients. So I will comment these studies, and as you can see, in cheap administration of angiotensin II versus placebo increased mean arterial pressure, has no effect on heart pressure, slightly increased light vehicle cardiac output has no effect on mesenteric blood flow. Coronary blood flow was increased in both drug, vehicle, or angiotensin II, and iliac blood flow was not altered. So in a second experimental study in pigs and in rather long-term model, sepsis was induced by fecal peritonitis, and the animals was monitored for a rather long time, 2 days. So the author has compared norepinephrine versus angiotensin II administration, and in a third group, they pre-treated the animals with enalapril, and they resuscitated the animals with norepinephrine. Here are the results. Mean arterial pressure is increased with norepinephrine alone or angiotensin, and pre-treatment with enalapril induced a decrease in mean arterial pressure. There was no effect on cardiac output, no effect on mean pulmonary artery pressure, and no effect at all on stroke volume. The only trial in human being is the ATOS trial, a pilot study, and as you can see, the sample of patients was very small. 10 patients were treated with angiotensin II administration, and what report the authors is that when you infuse angiotensin II in patients, you induce a decrease in norepinephrine requirements. And in this short-term study, they assessed secondary outcomes, but there was no effect of angiotensin as compared with the norepinephrine. So urine output, cardiac output, central venous pressure, mean arterial pressure, and lactate were the same in the two groups. So the classical picture is, you know it, and what happened and what could be happened when we have a lung injury, for instance, is the angiotensin 1 could be cleaved in angiotensin 2 and exert its peripheral effect. The same question for kidney injury, what happens with renin release and with the liver, with the production of angiotensinogen. So I will focus on lung and kidney and don't speak about the liver production of angiotensinogen. So in septic shock patients with acute respiratory distress syndrome and infusion of angiotensin II, is there a potential risk? So the good news, and it's SHOCKLe hypothesis, and in his opinion, a damaged lung may reduce pulmonary capillary activity and thus angiotensin II release. Therefore, there is a strong rationale to infuse angiotensin II. The bad news is that angiotensin II is maybe a lung poison. Maybe it has a very strong effect on vascular constriction, but it has its own peripheral toxic effect on tissues and especially on lung. The problem is that renin-angiotensin system is much more complicated than we have learned. Indeed, we have the mainstream pathway, and that's what we have learned, but we have two kinds of receptors, angiotensin 1 receptors, which has very bad side effect for the lung, and we have angiotensin 2, which is activated by angiotensin 2, but also angiotensin 3, and it counteracts the effects of angiotensin 1. The new angiotensin-converting enzyme 2, which was discovered recently, has protective effects, and it cleaves angiotensin 2 to angiotensin 127. And it combines with two receptors, which are MES and prorenin receptors. It has anti-inflammatory effects, anti-apoptotic, and is associated with vasodilation. So the picture is a little bit more complex than we have previously thought. And I recommend you to read this paper from EMA published in Nature, which depicts the effects of the different receptors with stimulation of AC and AC2 with recombinant AC2 drugs. And they use also genetically modified AC and AC2 knockout. So I will, for sake of time, I will not comment that, but I urge you to read this paper if you are interested in this topic. The effect of AC2 are protective, and in knockout animals, you have improvement of, in non-knockout animals, you have improvement of wet-to-dry ratio. When you have a knockout AC2, which is protective, usually you have more capillary leakage, and with this nice blue events, and the effect of AC2 leads to improvement of PaO2, FiO2 ratio. So to summarize this very complex and crossmark study, this picture, you have to keep in mind this picture. And when you have a lung injury, you have mainly a stimulation of the main strain or the main pathway of AC, which stimulates angiotensin II, and also consequently AT1 and AT2 receptors. AC2 has protective effects and inhibit angiotensin II. AC2 is angiotensin 2-17. So to summarize the publications, it would be useful to use blockers, for instance, or maybe angiotensin 1-7, which protect lungs from inflammation. So if we have to use, regarding the lung, something, it would be better to use angiotensin 1-7 rather angiotensin 2. But angiotensin 1-7 has no the same effect on peripheral vessel, for instance. So what about the renin-angiotensin inhibition and ARDS? Most of the studies have used beta angiotensin 1 receptors, and which is losartan, but also candesartan, etc. And when you give Bordetella bronchioseptica in animals, you have a decrease in PaO2, FiO2 ratio, and when you add losartan, you have an improve in PaO2, FiO2 ratio. So the gas exchange are improved, and the survival also is improved. So the effect of AC inhibitors were also tested in rat model, and in white here you have the animal who were challenged with LPS, and in hatchet bars you have those who were challenged with LPS and treated with enalapril. As you can see, the sign of inflammation and edema are decreased with the combination of the LPS and the protective effect of enalapril. And the wet-to-dry ratio was better when we use when we add enalapril. And the myeloperoxidase activity was also improved and goes down, sorry, with enalapril, arguing for a protective effect and antioxidant effect. So, what about the kidney now? And you have to remember, when we give angiotensin II, we increase the tonus of the afferent arterioles, which is in series with the peritubular capillaries. So when we decrease the flow there, we induce the risk to lead to ischemia of the peritubular arteries. So there is a risk of threaten when we use angiotensin II on kidney, especially on peritubular capillaries. So what happens in animals when we give in sheep, when we give angiotensin as compared with vehicle, angiotensin decreases renal blood flow as compared with the placebo. The renal conductance is also decreased with angiotensin, but fortunately, there's no bad effect or a worse effect on kidney function. As you can see, the urine output was better with angiotensin, and the creatinine clearance also was improved with infusion of angiotensin II. It is a very short model of animals, and caution is mandatory. The second experimental trial study compared angiotensin in septic sheep. So you have the window of angiotensin administration there, and when the author have infused angiotensin II, mean arterial pressure has increased. The heart rate was the same. The variation of renal blood flow goes down in both groups, sepsis and sepsis plus angiotensin, and renal conductance decreased more significantly with angiotensin. So maybe it's a bad signal. So in this study, they have used conversely to the addition of agonists, they have used an antagonist, renin-angiotensin system antagonist, which is candesartan, angiotensin receptor blocker, and the dose was tuned in order to avoid a decrease in mean arterial pressure. So the animals treated with candesartan here decreased very slightly their blood pressure. The renal variation resistance decreased, and the renal blood flow also was there with candesartan. Sorry, it was increased there. So the blood flow, conversely to angiotensin II, the blocking of the renin-angiotensin system with candesartan improves the renal blood flow. And they measured the oxygen availability in cortical area and in the outer medulla with laser Doppler, and there was no effect in the outer medulla here. But in the cortical zone area, there was an improvement of oxygenation. So, however, there was no effect at all on kidney function. So, glomerular filtration rate was the same in the three groups. So, when we look at the data regarding the acute kidney injury occurrence in patients already treated with AC inhibitors or angiotensin receptor blockers prior to septic shock, there is a consensus, and all these studies report detrimental effect when patients are treated with AC inhibitors or ARB. This means that when patients receive this kind of drugs, they are at higher risk to develop renal failure during the septic shock phase. Here are depicted the ongoing trials, and we are eager to have the results, but as you can see, the approaches are very different. Some want to give angiotensin II, but others have a completely opposite approach, and they try to give antagonists or inhibitors. So difficult to have a definitive conclusion. So to conclude, we do not deny that angiotensin II is a potent vasoconstrictor. However, angiotensin II is a multifaceted drug, and renin-angiotensin II in septic shock has a very complex pathway. And administration of angiotensin II in septic shock is a promise drug, but we should pay a lot of attention to the potential delayed detrimental effect, especially on lungs and kidneys. Thank you.